Alison, I can't hear.
Hello, can you hear me, Alison?
Yes, James.
Yeah, brilliant. So yeah, Alison's, I'm not sure what's going on Alison's side. Can you speak, Alison? Can you hear me? You want to unmute yourself? I can't hear you. I think you muted her. I guess, so I don't know if I can unmute you. So anyway, I'll introduce you to the session and hopefully Alison get audio working in the interim. So today's session, we've got 3 videos to watch. So we're going to start first of all with the equality video. So I'm going to press play on that, and then hopefully by obviously the interim, Alison will be able to get her audio. So Alison's going to be helping to kind of organize the infrastructure of the session and obviously the Q&A, etc., and the timing. So I'll just launch the videos now, and then obviously by the time hopefully the first video is finished, Alison will be able to get her audio working.
Many thanks for the introduction, Alison. My job today is to enthuse you about the benefits of adopting a health equity mainstreaming strategy to strengthen the way we do research in your organizations or in your teams, with the goal of reducing health inequalities and improving health. The need for this strategy is sparkled by 3 factors. The first one you know very well, and is the very sad increase in health inequalities across the country. And COVID has exposed and magnified these inequalities, as Michael Marmot in this quotation explains. These inequalities are the main cause of premature death, unnecessary suffering, disabilities, and distress. They are affecting individuals, communities, and professionals alike, and cost money to the country. The second factor is the long history of policy development on health inequalities in the UK, the EU, and the World Health Organization. In other words, as professionals, we do have a duty to tackle health inequality. And the last factor that triggered the need for this strategy was the awareness of a systematic lack of health equity considerations in applied health research. That's, in other words, there is a lot of research produced, really wonderful research, but it's not health equity focused. That means we don't know whether things work, for whom, and under what circumstances, and they might focus in particular socioeconomic group at the expenses of other groups. And we don't know whether some interventions increase inequalities. So that lack of health equity focus has massive implications in policy and practice. So our argument with this strategy is that we do need to change the way we do research, and it's of vital importance because we need to produce new knowledge that identified the root social conditions that influence ill health. Only by identifying and understanding those pathways of inequalities, we can use that knowledge to influence policy and change. And only then, when we change that practice, we can actually start seeing impacts on health outcomes. How is this approach different? I'm really proud to say that this is the first strategy of its kind in research collaborations. As I say, there is a very long history of policy on health inequalities, but has been very, very little work that is trying to embed a health equity focus across research collaborations. So this strategy is different in a number of ways. First one, as I've been emphasizing throughout the talk, is that it focuses on the social determinants of health. Our research seeks to identify the underlying causes of health inequalities and to address this. The goal is to improve health and well-being across the social gradient, but we cannot improve well-being across the social gradient if we don't tackle inequalities first. The second approach is that it brings together researchers, communities, and practitioners' knowledge, skills, and experiences. So each of researchers, communities, and practitioners, they have a different part of the jigsaw in understanding health inequality, and it's by bringing together all these different parts of the jigsaw that we can maximize the way we identify and implement solutions. The third approach that makes us different is that we want to have systemic change in the way we do research. Again, as I say, there is very limited evidence on effective interventions to reduce the social determinants of health inequalities. So this strategy aims to change that. This strategy aims to foster the routine integration of a health equity focus into all stages of research. This includes the research design when we think about research questions, research hypotheses, and also includes implementation, the way we do things, disseminations, the way we communicate findings, and evaluation, the way we assess whether our work increases inequalities or not, whether our work benefits particular socioeconomic groups or not. Another factor that make us different is that we want to use research finding to influence policy and practice to advance equity. We want to go beyond producing beautiful papers that nobody reads. We want to use those papers to influence policy debates and practice improvements. And our aim with this strategy is to build research knowledge, awareness, competencies, and capabilities among ARC staff, but also our member organizations, among you. And to do that, we want to draw on your expertise, because many of you do have that expertise. So it's how we can harness that and bring it to build the research capacity of other colleagues. Our aim is also to co-produce health equity sensitive applied health research. So that means co-production means bringing your wisdom, but also working with members of the public and communities to bring those different pieces of the jigsaw. Also really important, this strategy aims to strengthen institutional mechanisms for health equity mainstreaming within ARC. What does it mean by institutional mechanisms? It means processes, how we can improve processes and structures, how we can support researchers to actually integrate a health equity focus. That's what we want to do. Also, we want to engage member organizations, we want to engage you, and we want to engage our amazing public advisors to become health equity champions. So we can become an army, and we can actually infect different departments and units and projects within our organizations, so they integrate a health equity focus. And finally, as I say, really want to emphasize, we want beyond just publishing research findings. We want to use those research findings to influence policy and decision makers to advance equity. So that's me. Now the questions, we have a few minutes to discuss, is how does your organization existing work lends itself to embrace this strategy, and what programs and processes could be improved, and how we could support you. So please, we would like to hear from you. Thank you very much for your time.
So Anna, are you okay?
Many thanks for the introduction, Alison. My job today is to...
There we go. It's all right. It's paused. I'm just going to exit out just so we don't have that accidentally playing. Are you okay to answer questions, Anna?
Yes, I'm here, I think.
You are. I can hear you, and I think everyone else can hear you.
Any questions? It could be very good for us to learn, because we know that member organizations, you are doing already really good work on health equity, and it could be good for us to know what you are doing and how we can combine and adapt the work you are doing to embed it in the research process. So any ideas? Silence.
So if anyone's got any questions, you just need to unmute yourself.
Can you hear me, James?
Yes, I can. Yes. We can hear you.
Oh, right. I think there might be a problem with the mute function.
Is the chat?
Okay. Well, if nobody's got any questions, perhaps James, we could move on to the next presentation by yourself on the systematic reviews.
Yes, certainly. I mean, what we can do is if people's having problems with mutes, if you want to post your questions in the chat bar. So on the right hand side, you'll have obviously the chat bar. And what we can do is when we finish the next video, we can answer obviously the questions which have been building up in there. So if you have any questions alongside the video at any point, please just put your questions in there and we can answer it that way. Or if you want to demute yourself and obviously ask during the question periods, that'll be fine. So it's going to play the second presentation. This is some work which we've been doing around COVID-19 and these 3 systematic reviews. So I'll let the video explain the kind of main contents.
Good afternoon. My name is James Hill and today we're going to be talking about mass outbreaks and mental health. This is part of the COVID work which we've been doing within MIDAS. We're going to be addressing 3 systematic reviews and describing the findings and implications to practice. So the 2 systematic reviews which I'll be talking about today is regarding the prevalence and incidence of mental health conditions for healthcare workers, and we also did a similar systematic review for the general public with the same kind of PCO variables, which I'll be discussing in more detail later. My colleague Alison will be discussing the psychological effect of interventions which can be used to prevent some of the mental health impact for healthcare workers and the general public during outbreak periods. So as previously identified, I'll be talking about the 2 prevalence and incidence reviews. I'll mainly be focusing on prevalence today due to the lack of evidence identified in the 2 reviews on incidence. So the populations we were focusing on for the 2 reviews were healthcare workers and the general population who experienced a pandemic. And what we wanted to know is out of this 2 populations, what percentage could present with mental health conditions and symptoms. For the conditions, we only used tools which were validated, and we only used the particular threshold which has been linked to a clinical diagnosis. So sometimes with these studies you'll get multiple scores for the particular tools. What we did is pick the one which was directly linked with the particular clinical diagnosis to hopefully increase the validity and reliability of the data. So how did we undertake the review? Both reviews used the same methods. It was a multi-database search carried out 8 months ago. We had 2 main populations as discussed previously, which we focused on, which was healthcare workers, and for the general population, we classified this as non-healthcare workers. The key is that both populations had to experience a pandemic. We carried out a dual assessment. So for study selection, we had independent study selection. For data extraction, this is where we take the information from the studies. We used a single author and another author verified or checked the results, and that's the same for the quality assessment. We carried out a meta-analysis and subgroup analyses. So this is where we summarized the prevalence estimates by putting them together to create a single point estimate. As part of this, we did a number of subgroup analyses and meta-regressions to identify any key association factors, so anything which we think might be associated with positive and negative prevalence rates for particular conditions. The main conditions which we focused on was PTSD, so that's post-traumatic stress disorder, and anxiety disorders, major depression disorder, and psychological disorders. We did look at symptoms for all these conditions as well, which I'm not going to focus on today as I've only got a short period of time, and we also looked at other conditions, so acute stress disorder as well, which was in there. So these are the main 4 particular impacts which we'll be talking about today. So if we take a look at the 2 findings of the reviews, What I've done to kind of make it easier to interpret the data, I've put in the middle kind of the atypical prevalence rates which would be expected in the general population worldwide prior to a pandemic period, just to give some context to the numbers which will be in the pie charts. So the first condition we're going to look at is PTSD, and PTSD was quite similar in both populations at 21 to 22%. You'll see this is substantially higher than what's typically expected in the general population. Next to this was anxiety disorder, and atypically we'll be looking at 7.3% of the general population presenting with anxiety disorders. You'll see this is substantially higher again at 13% in the general population and 16% in the healthcare workers. And the third kind of most prevalent condition was major depression disorder, which is typically around about 4.7% in the general population. You'll see this is also substantially higher at 13% in the healthcare workers and 14% in the general public. I also mentioned that we did do symptoms of these conditions. So the symptoms had quite wide variation because of the wide range of tools used. So for these conditions, we ensured that we used specific clinical validated tools and use the particular threshold which has been linked with that condition to allow us to have narrower confidence intervals and also more consistent in the evidence base. To give you some kind of context of the kind of wider effect, so these may not be issues which will be at a point where it's clinically to be diagnosed as a condition, but kind of showing you the overall impact. We also collected data from the GHQ 28, which relates to psychological distress. So we did quite a low threshold of a score of 5, but it's an indication that there's an issue which is something which should be addressed. So that even at a low threshold, it's something which is relatively clinically relevant. So what I want to show you here is that the general public had kind of a higher prevalence rate of this particular assessment tool. So in the sense they may not be clinically diagnosed conditions, but in the sense they are experiencing a relatively higher level of distress compared to the healthcare workers at a point where, you know, I mean, something would need to be addressed or assessed at that point. As discussed, we carried out a range of subgroup and meta-analyses to look at things which can help us identify important factors which may influence the prevalence of the particular conditions. So for pre and post, so we wanted to know if there is a difference between during the pandemic and after the pandemic. We found that healthcare workers had a lower prevalence of PTSD, post-traumatic stress disorder, and anxiety disorder after the pandemic compared to during the pandemic. However, for the general public, we found this was inverse. So in the sense of the PTSD and anxiety disorder was higher after the pandemic than during the pandemic. The other element we found was important, that gender played a role, that females had a higher prevalence of anxiety, and this was in the healthcare workers, and we also found that there was a higher prevalence of PTSD and major depressive disorder in the general public. Other factors which we found important was level of exposure. So as you would typically expect, the healthcare workers who were closer to the front line, so these ones who were working in ICU or specific pandemic wards, had a higher prevalence of PTSD, anxiety disorders and MMD. And similar for the general public, the ones who had a family member or in the sense were exposed themselves to the pandemic directly, so if they had the disease, they had a substantial higher, statistically significantly higher prevalence rate of PTSD and major depression. For country, we found that there was kind of a variance between them. So certain countries had a higher prevalence than others. So one of the examples comes to mind was the China had a significantly lower level of PTSD and major depression compared to 7 other countries we compared it to. So there is quite a variance between countries in regards to what they would typically expect in prevalence rates for these particular conditions. We only did this examination for the general public, but we found that if you're a carer, you had an increase. There was an increased prevalence of MMD compared to people who were not carers. The other element which was quite interesting, obviously helps us to validate our approach, is that we didn't find a substantial, any statistical significant difference between the pandemics. So we looked at in both reviews, I think about six or five different pandemic types, and when we subcategorized them into different pandemic types, we didn't find a substantial difference between COVID-19 and previous pandemics in regards to prevalence rates of these conditions. So what are the main taking-home messages? So obviously the general public and healthcare workers are substantially affected with a wide range of psychological symptoms and conditions which are higher than what's normally experienced compared to non-pandemic periods. So this is something which we need to be aware of and also need to prepare for, and especially in regards to that finding that the prevalence rates continue to increase after the pandemic period. So for the general public, some of these conditions increase more than what we experienced during the pandemic period. The other main findings is that the COVID-19 is similar. So we found that the kind of exposure rates, what we experienced during the pandemic of COVID, theoretically will be similar to what we've experienced historically. So we should be expected to have some of the similar patterns and levels of prevalence rates for these conditions. The kind of two elements which I want to emphasize is that obviously this is an evolving area. So I know when I was doing it, the reviews studies were coming out daily. So there is obviously a wide base of evidence which is coming out. One of the things we have made a recommendation for both reviews is that obviously they'll need updating relatively sooner than later because of the constant evolving evidence base. And what I'm going to do now is pass you on to my colleague. So I'm going to pass you on to Alison, and Alison will focus on the kind of things we can do to prevent some of these issues and some of these increased prevalence rates.
Hello, I'm Alison Doherty. I'm the ARC-MIDAS theme manager, and I'm also a research fellow with the University of Central Lancashire. My presentation today concerns our COVID-19 related systematic reviews, one of which explored the effectiveness of interventions to address the psychological impacts on the general population and healthcare practitioners exposed to mass outbreaks. Over a decade before COVID-19, countries were expecting an influenza pandemic of unpredictable scale and impact. Fears and concerns were around sickness and death rates, but also concerns were around the impact on mental health and well-being. Previous experience from outbreaks such as SARS had highlighted the impact on healthcare workers. The SARS outbreak caused considerable distress to between a third and a half of healthcare practitioners. 2 years later, after the outbreak, healthcare practitioners that had treated SARS patients had elevated signs of chronic stress compared to those working in hospitals that had not worked with SARS patients. Building resilience and reducing the impact on mental health before, during, and after a pandemic is vital. Some people are more vulnerable to mental health problems, such as BAME communities, young people, older people, and key workers. Several forms of mental health support interventions may be advocated, but some may lack efficacy. Our systematic review aimed to explore the effectiveness of psychological interventions to support those exposed to or more vulnerable to mass outbreaks, such as mass infectious disease outbreaks, for example, SARS, MERS, Ebola. Our review included all types of studies that assessed the comparative effectiveness of psychological interventions provided to the general population and healthcare practitioners. We excluded studies of interventions for people exposed to war, terrorism, natural disasters such as tsunami. And we excluded studies that included armed forces, police, firefighters. We only included studies published in the English language. Effectiveness of the interventions was measured by measures in changes in psychological impact, such as reduced anxiety or depression. Our systematic review followed a predetermined and published protocol and reporting standards for systematic reviews. We identified studies through searching electronic databases using a predetermined search strategy. We looked for psychological interventions for healthcare workers and the general population exposed to mass outbreaks. Our study selection included all types of studies that assess the comparative effectiveness of psychological interventions for those exposed to mass infectious disease outbreaks. Data was extracted by 2 independent researchers using a pre-piloted data extraction form, and the risk of bias was assessed by those 2 independent researchers as well. We searched studies for any health inequalities implications. We expected to find a lot of different studies, and so a narrative summary and a tabulation of results was undertaken. The search identified over 5,000 citations. After screening, we identified 8 eligible studies. Of these 8, 3 were randomized control trials, 2 were quantitative descriptive studies, and 3 were qualitative studies. 6 of the identified studies focused on interventions for healthcare practitioners, and 2 focused on interventions for the general population. The study settings included low-income countries such as Sierra Leone and Liberia, and high-income countries including Hong Kong, Taiwan, and Canada. 4 of the studies focused on interventions for those exposed to Ebola. 2 focused on interventions for those exposed to influenza pandemics, and 2 focused on studies for those exposed to the SARS outbreaks. 2 were studies of pre-pandemic interventions, and these were concerned with pre-influenza pandemic outbreaks, and both of those were conducted in Canada. The SARS interventions, one of those was looking at interventions for patients with pre-existing chronic health conditions, and the other study looked at psychological support for healthcare practitioners working with SARS patients. The studies focused on Ebola included cognitive behavioural therapy for patients exposed to Ebola, telephone support group, and future resilience psychological first aid programs for healthcare practitioners. And we also identified a psychosocial arts program for children exposed to Ebola. The studies reported finding improvements in mental health conditions such as depression and anxiety. However, there were limitations. We identified few studies. The studies that we identified had small sample sizes, and the studies themselves reported challenges in recruitment, particularly during the time of the pandemic. There may have been positive reporting bias. For example, participants may have feared losing their treatment, or practitioners may have feared losing their job if they gave negative responses. There was limited information on the actual components of the interventions and/or how they were implemented. And the studies were mainly conducted in countries that had experienced outbreaks previously, apart from the pre-pandemic interventions conducted in Canada. None of the studies were conducted in Europe, and only one study involved children exposed to a mass outbreak. So there was a lack of published evidence, and also a need for further large-scale randomized control trials and longitudinal long-term studies are needed. We need immediate and long-term mental health support for children, young people, older people, BAME communities, and those with pre-existing chronic health conditions. and also those experiencing bereavement, domestic violence and job losses during a pandemic. In the meanwhile, what can we do to support ourselves? Well, it's important that we're kind to ourselves and that we take care of ourselves and others, that we listen to our doctors and healthcare organisations, we stay connected with our communities and engage in activities that bring us joy. We should also follow reputable sources about the outbreak, such as Public Health England and the NHS. And we may wish to look at the 5 ways to wellbeing principles, which are demonstrated in this image here. So about connecting with others, keeping learning, taking notice, giving back and being active. So I'm just here today presenting on behalf of the wider review team involved in this systematic review. I'd like to thank them all for their input, and also Geeta, our clinician, who originally came to us requesting this systematic review. And finally, I'd like to acknowledge and thank our public advisors who contributed to this systematic review. Thank you for listening and for taking the time today. So it's me again.
Yeah, I'll pass you back.
Thank you. Has anybody got any questions for either myself or for James? I've just got a bad cough there. Well, if nobody else has got any questions, I had one for, I think there's one in the chat actually, for Anna. Leo.
In which chat?
It's in the Atifire chat on the right hand side. I think
Are you okay to read it out, Alison?
Yeah, yes, please. I'll read it out. So it's, thanks for you. So it's for you, Anna. Leo says, thanks for your enthusiastic intro. And he wants to know how MIDAS can support a starting researcher from a partner university who's approaching health inequalities from outside the ARC Northwest Coast, but is interested in collaboration. He's wondering how we, MIDAS, can support him with his health inequalities research. He might want to expand on that himself. He might be here.
Leo, are you there?
Yes, hello.
Hello.
Yes, so I'm basically, if you could tell me a little bit about any standard procedure, who to approach, and because I've got ideas and I've got elaborated proposal that is not completed yet, and so yeah, I don't know what is there in MIDAS.
Alison, you want to answer that about the prioritization form? Do you? So I'm not sure. Can anyone hear me?
Yeah, we can hear.
Yeah, I think probably the best bet, perhaps Valerio can put the email address side of this Atifire.
Yeah, I will do
Is that okay? Yeah, come and have a chat with us, Leo. Yeah.
So yes, so Leo, it might be better if you approach us by email, but in general there is a form that colleagues interested in joining us have to, or could be good that they could complete, so we can know what they want to do, how it fits with the ARC priorities, and also we can anticipate how much resource you might need. But it might be worth that you contact us by email. My connection is breaking, maybe. I can't hear it.
No, we can hear you.
I think this is Andy Clay just saying, I think, Leo, there's probably two things, as Anna says. If we start having a sort of initial conversation with you about it, if you email we can arrange a meeting to talk about it and then look at what sort of things you're looking to do, and then advise you on the sort of next steps to go through, because we are looking to try and help support people in all sorts of different projects associated with health equity. So we don't just tell people that they need to do it, that we help them engage and take on developing ways to approach health equity for whatever type of project it is, whether it's a PhD proposal, a randomized control trial, systematic review, etc. So if you email us, and I'm sure we can put the email address in the chat, then we can arrange to have a chat about it. But we would look to try and support you depending on how much resource it required and what you were looking to do. Does that answer your question?
Yeah, he's put in the chat bar. Yeah, that's fine. He will contact us.
Okay, we've got another question from Peter Lloyd about what steps are in place to connect the EPIC theme to look at these issues in context for particular localities. Peter, is that to do with health inequalities presentation, or are you talking about the COVID-19 related issues?
Can you hear me? I've had all kinds of trouble. Can you hear me?
I can hear you.
Okay.
For one,
okay. I've had trouble with the system. What I'm looking for there, I thought it was an excellent presentation. And at the top level, it seemed to me that downloading it to the ground, you were looking for longitudinal studies for more controlled trials. It seems to me that there is a real link there with what I heard this morning from the EPHC group. They're looking to open up channels for work, and it seemed to me this is an obvious channel in the mental health sphere.
Yeah, that's a very good point, and I'll look forward to chatting to Paula Wheeler about how that we can collaborate on that issue. I'm just conscious, and we've got one more presentation, and then we can stop sharing the screen and have a proper discussion, if that's okay with everybody. So, James Hill, could you do the third presentation from Joanna Harrison, please, on our races? Thank you.
Hello, my name's Joanna Harrison, and together with James Hill, we work on the Rapid Conversion Evidence Summaries project, RACES for short. We've prepared this presentation to explain a little bit more about RACES, what's involved, the impacts it's had so far, and how to find out more. So what are RACES about? Primarily, they are about identifying clinically relevant, high-quality evidence in the form of systematic reviews. This evidence is then converted into a short written evidence summary. RACES are driven by a clinical research question, which usually arises out of a clinician's usual practice. Working with academics to identify, understand, and summarise the evidence available, a clinical academic partnership is formed. As the name suggests, RACES are completed with a quick turnaround, usually around a month, from identifying evidence to having a finished evidence summary ready to go. Finished RACES provide evidence to help with clinical decision-making in practice. They can also help to inform organisational change through summarising the relevant evidence when developing services. All RACES are disseminated within the clinician's practice at a team or trust level. They are also published to a wider audience through a peer-reviewed publication in a relevant clinical journal. At a project level, RACES has three main aims. Firstly, to develop clinical academic writing skills and an understanding of systematic reviews. This will help to build research capacity and capability at both an individual and organisational level. Secondly, RACES aims to disseminate research evidence and implement change at an internal level, that is, within the specific clinical area or organisation. Thirdly, external dissemination is always encouraged through publishing the summary or commentary within a relevant publication. So what's involved in undertaking a RACES? Firstly, the ARC member contacts us with a clinical research question or area of practice they are interested in developing. We can then help to ensure that the research question is appropriate for a RACES project, primarily that it will help to support the process of clinical decision making. Subsequently, we can help with identifying a relevant systematic review that is both useful and of high quality. To guide this process and the writing of the RACES, we use Microsoft Teams as a learning tool. Members are allocated a team space where they will find a step-by-step guide to producing a RACES, including lots of useful links to videos and relevant literature. The team space also allows for communication with other team members, both clinical and academic, and also a space in which they can jointly work on the evidence summary. On completion of a RACES, the academic team will help with quality assurance. Following a successful sign-off, the recommendations from the evidence summary are then disseminated and, if applicable, implemented into practice. Finally, a relevant journal is identified for submitting to publication. Here are some examples of completed RACES from different clinical areas. These two-page summaries are designed to be clear, informative, and easy to read in a short amount of time. The key points are always summarised at the top of the front page. Here are 3 examples of published RACES in peer-reviewed journals. As with all published articles, each journal has its own style and may refer to the summaries by different names, for example, commentary or research review. The content of each published article, however, is always informed by the original 2-page summary. We also respond to requests from journals to provide an evidence summary relevant to their need and focus. In this situation, we seek to identify a relevant clinician within a partner organisation who may be interested in writing an evidence summary. This slide shows the full list of RACES that have been published since the ARC began. We have 12 publications in total and also have a further 3 articles in press. Publications are one of the many ways in which RACES makes an impact. They are also a great opportunity to develop clinical academic partnerships, helping to build both the capacity of member organisations to undertake research and their capability. They offer a route for dissemination, both internally within the organisation and externally to a wider clinical audience. They also help to improve clinical knowledge by keeping up to date with the best clinical evidence available, and subsequently inform both practice and service development, implementing change based on evidence recommendations. Examples of impact achieved by RACES include the adoption of continuous quality improvement methods to improve healthcare. A RACES project was completed to help an NHS trust interpret a review of continuous quality improvement methods. Based on its findings, the trust adopted some of these processes. In another example, a staff training session was completed based on the identified recommendations to improve medication adherence for stroke patients. This RACES was also published in the British Journal of Neuroscience Nursing. Another source of impact includes a trust that was looking to roll out a safety culture tool and were unsure which one to use. The RACES process identified a relevant review, and based on the findings, the trust selected the most reliable and valid tool for rollout across the trust. Impact has also been identified in building research capacity and capability. A clinician who worked on a RACES project found that it built confidence in writing and subsequently helped in applying for a successful research internship with a view to developing a clinical academic career. We hope this presentation has provided you with an explanation of RACES and how it might be useful to you or your organisation. If you would like to find out more or discuss further, please contact me on the email below, jharrison12@uclan.ac.uk. If you already have a clinical research question in mind and feel ready to start a RACES project using the MS Teams guidance, please contact James Hill for further discussion. James can be contacted on the address below, jehill1 www.uclan.ac.uk. Thank you for listening. If you have any questions, James and I will be happy to answer.
So, is there any questions about races? Joe, are you there?
Yeah, I'm here. Oh, there we go. Hi.
Yeah, yeah. So does anyone have any questions about races, or how do you go around races, etc.? I'll let either people type or demute themselves, whatever's easiest for them. Silence.
James, there is a question from Paula Wheeler that says whether there is a non-clinical offer for races.
Yep. So in the sense of the question doesn't necessarily need to be directly clinical related. It has to come from one of our members. So theoretically, it needs to come from one of our 61 members. So it has to be specifically relevant to one of their needs, but it doesn't necessarily need to be clinically based. The key is to identify a relevant systematic review underpinning the clinical question. So in different fields, systematic reviews are developed in different ways in the sense of how many are done in certain areas. Obviously, historically, systematic reviews are mainly based in kind of medical or clinical areas, but there are non-clinical systematic reviews. So yeah, so certainly if there's a specific question is not directly clinically related, it's fine to have a look at there is any evidence underpinning that area and then look to identify a relevant review.
Thanks, James. It's Paula. Sorry, that's really helpful. I think it aligns to what Peter was saying earlier about us being smarter within and across the ARC themes, being able to avail ourselves of your brilliant expertise in the methodological team. Quite a lot of the work that we're exploring and already the research we're undertaking isn't clinically focused in the way that you've described from some of the races that you've already undertaken. So, for instance, the air quality angle was very much around community engagement and public participation in the crafting and design of the protocols. But it's helpful to know that we basically have to slice our cake a bit differently if we want to avail ourselves of the races function. So that's great to know. Thanks.
Yeah.
Thanks, James. There's just a couple more questions. There's one from Selena Wallace about how or do we get public advisors involved in the races?
So, yep, so this is a more recent development. So the races have been kind of a maturity model. So what we've been trying to do is we wanted to make sure the process initially was well established. So when we offered it out to all the members, they had a well established and robust methodology, which we're kind of up to that process now. The next stage is to get service users involved. So we want to see it to be productive for everybody involved. And a part of that we think would be a good input would be, we've already got the kind of, at the moment, 12 already published 2-page summaries. And they're kind of written in a context to bridge the gap from something which could be a very complex systematic review to more of a clinical interpretation. So it kind of makes very simple recommendations of how you would implement the findings to practice. We would find the next step, which would be helpful for these 12 commentaries, would be having a patient interpretation. So this is where we think we could get service users more directly involved, is actually making the next leap of disseminating the knowledge is actually writing a patient interpretation of the race summary. So we've got the clinical interpretation and we would expect them to be basing on the already 2-page summary. So hopefully they will find that the level of knowledge in regards to clinical area would be relatively lower because we've already took some of the technical aspects out of the review. So we generally try to avoid the statistics side of it and try to describe it in more practical terms instead of describing it from a statistical perspective. So we will say something maybe clinically significant we would do is obviously interpret it more in a descriptive term of what the decision would be in clinical practice. So the idea would be when you've got that midway kind of interpretation of the evidence, we would hope that somebody from the service user group could actually then make the extra gap and write another 2-page summary, or even probably shorter. We'll probably look for maybe a 1-page summary. But this is something we're looking to introduce over the next 6 months. So we haven't offered it out yet, but it would be, I think, a good way for obviously to initially get involved with race projects, because you're not trying to interpret systematic reviews for that type of level of, evidence. You're actually already having an evidence source which is already kind of already partly interpreted, and obviously it would be nice to have even a more plain English version of that, and that's where we think service users could be more directly involved.
So that's great. So it's more of an easy read sort of version that we're looking at.
Yeah.
I'm just conscious of the time. There's a couple more questions. How many people do you need to work on a races project?
It's scalable. Typically, it's somewhere between 2 to 3. So, I mean, it helps that there's 2 just in case. Obviously, then you've got capacity in the team to complete the project. So sometimes if there's only 1, you'd have to obviously have a larger commitment by an individual to do. It's typically only 2 or 3 days work. So depending on how experienced you are, that obviously time gets shorter by if you do more of them. But yeah, typically a 2-day or 3-day for a single person. And that's obviously divided by how many people you have in the group. So I think kind of an optimum number would be about 3. So you have somebody writing the intro, somebody writing the methods, and then somebody writing the findings, and then it's a collaboration for the commentary section, which is the implementation to practice bit, which I think as a group, it seems better when it's written by 3 people. So typically 3 to 4 would be perfect.
Okay. That's great. Peter Lloyd's asked, the Clark bites, the summaries that we did already look like initiatives for a races type work, and he was wondering whether there's a way that we could look back over those ARC bites and maybe re-recruit from those.
Yep, I think that would be, I'd say before kind of my time. Do you know anything about Joe? Do you know anything about the ARC bites, because you were more directly involved with Clark?
Yeah, I mean, we could look back at those and look at the topic areas and see if there were any systematic reviews completed in those areas, and then have a think about whether we want to contact the people involved in those to see if they would be interested in doing a races based on a systematic review in that area. That's definitely possible.
I had a very specific reason for asking this, because in Clark, I worked with a consultant geriatrician at Chester. We had a very nice project going on the elderly, frail and A&E practice. Unfortunately, he got very busy. That was a brilliant piece of work, and I think it was of national significance. But he dropped out, but the work is still there. It seems to me that that's the sort of thing where clinicians got busy afterwards. There are things probably in there that other clinicians or other people should root out and pick up. But certainly it's worth looking at the Countess of Chester initiative from the old Clark, because it was a very good piece of work that was on its way to being a proper piece of medical research.
Yeah, I remember that project, Peter. Along with, there was lots of good projects from that PPP3 round, so it might definitely be worth having a look back through those topic areas, and then James and I could have a think about contacting people to see if anyone would be interested in taking it further.
Thanks, everybody. I'm just conscious of the time. We've got like 2 minutes, so we'll probably get cut off. And there was just one last question in the chat about whether we do living rapid reviews for any ongoing questions. I'm not quite sure of the question from Martin Regan.
I think, does that mean ongoing sort of rapid reviews that are in the process of being completed? If we have a completed review of whatever type, with findings that would be relevant to clinical practice and decision making for clinical practice, then yes, we could do that. Yeah, we can look at all sorts of reviews.
Yeah, if I come in, what I'm thinking of, if you like an emerging question, which the evidence is just emerging, is likely to emerge for some time. I'll give you a specific example. For the question of are there any interventions to improve the outcomes of care home residents from emerging therapeutic solutions? Is something which is changing quite rapidly, so you get an answer now, but it's going to change rapidly over time. So something which actually is an ongoing process that runs with the pace of change and the way the evidence emerges, but tries to give a rapid response to people who are trying to formulate operational and policy responses. That's what I was thinking of, something along those lines.
Yeah, I think this is Andy Clegg here. I think the answer to that is yes. We have got some reviews that we're starting to look at doing them as live reviews because the evidence base is changing so frequently. We haven't done any yet, but that would be something that we would be open to doing, particularly as there's a range of areas where the evidence is moving very fast, and it would be good to be able to keep them up to date as that emerges because of the evidence.
Hi, Mark. We can see, but we can't hear you.